Hello everyone and welcome New Teen TV. Today we'll be covering a range of topics from intracranial pressure to different types of traumatic brain injuries. Let's dive right in. Let's start by understanding intracranial pressure or ICP. ICP refers to the pressure inside the skull, and it's crucial to maintain it within a normal range, typically 5 to 15 mm². Changes in brain tissue, circulation, or cerebrospinal fluid volume can all impact ICP. Think of your skull as a rigid container. Any swelling, bleeding, or increase in fluid has nowhere to go. And that's what makes elevated ICP so dangerous. This diagram illustrates how ICP can fluctuate. We see the normal state, a compensated state where the body adjusts, and a decompensated state where ICP becomes dangerously elevated. Notice how the volumes of blood, brain tissue, and CSF shift in each scenario. In the compensated stage, the body might shift CSF to the spinal canal or reduce blood flow to balance pressure. But once compensation fails, brain damage can occur rapidly. Elevated ICP can manifest in several ways. Be alert for symptoms like decreased consciousness, pupillary dilation, and headache. Cushing's triad, hypertension, bradycardia, and irregular respirations, is a critical sign of severely increased ICP. Cushing's triad is the brain's cry for help. It's often a late sign, so early recognition of other symptoms is key to preventing herniation or death. Here's a more comprehensive list of symptoms associated with increased intracranial pressure. Remember to assess for changes in LOC, headache, pupillary changes, posturing, speech alterations, seizures, vital sign changes, and vomiting. In infants, look for bulging fontanelles, cranial suture separation, and a high-pitched cry. Now let's discuss level of consciousness, or LOC. LOC reflects a patient's self-awareness and reaction to their environment. It involves cognitive function and relies on the upper brainstem, reticular activating system, and cerebral hemispheres. LOC exists on a spectrum. Alertness represents the highest level, followed by lethargy, obtundation or stupor, and finally coma, which is the lowest level of consciousness. Recognizing these different states is vital for accurate assessment. You can think of it like a dimmer switch. As brain function declines, the light of awareness gets dimmer and dimmer until it's off completely in coma. Moving on to traumatic brain injury, or TBI. TBI results from sudden physical damage to the brain. Injuries can be closed or penetrating, and concussion is a common type. Falls are a frequent cause, and males are statistically more affected than females. Understanding the mechanism of injury, or MOI, is crucial in TBI. Blunt trauma, acceleration-deceleration forces, coup-contra-coup injuries, penetrating injuries, and blast injuries can all cause TBI. Each mechanism can lead to different types of brain damage. Coup-contra-coup injuries are particularly interesting. A coup injury occurs at the site of impact, while a contra-coup injury happens on the opposite side of the brain as the brain rebounds. This can result in damage to both areas. Imagine shaking a snow globe. The fluid and contents inside crash to one side and then rebound. That's what happens to the brain in a coup-contra-coup scenario. Cerebral perfusion is essential for brain function. Cerebral perfusion pressure, or CPP, depends on mean arterial pressure and ICP. The brain maintains normal blood flow within a CPP range of 150 mSv through pressure autoregulation. When CPP drops too low, brain tissues don't get enough oxygen, leading to ischemia. When it's too high, it can cause swelling. It's a delicate balance. Increased ICP can stem from various causes: cerebral edema, trauma, hemorrhage, tumors, inflammation, and ischemia can all contribute. Even compression of the jugular vein can elevate ICP. It's important to remember that ICP isn't just a result of major trauma. Even something as simple as improper head positioning in a hospital bed, like turning the neck sharply or laying the head too flat, can impair venous outflow and raise ICP. To decrease ICP, several strategies can be employed. These include external CSF drainage, lowering blood pressure, using hypertonic IV solutions, controlling carbon dioxide levels, and, in some cases, surgical interventions like lobectomy or decompressive craniectomy. Brain death represents the irreversible end of brain activity. It's characterized by coma, absence of brainstem reflexes, and apnea. Increased ICP can lead to brain herniation, such as transtentorial herniation, where the temporal lobe is compressed. This diagram illustrates brain herniation. Herniation occurs when brain tissue is displaced due to increased pressure. Understanding the different types of herniation is crucial for recognizing and managing this life-threatening complication. Think of the brain like a sponge inside a sealed box. When the pressure gets too high, the sponge gets pushed through the openings. That's essentially what herniation is. When assessing a patient with suspected TBI, a thorough examination is essential. Look for signs of head trauma, conduct a neurological exam, and assess LOC, mental status, cranial nerve function, and motor and sensory abilities. Also, consider the duration of unconsciousness and post-traumatic amnesia. The Glasgow Coma Scale, or GCS, is a standardized tool for assessing brain injury severity. It evaluates eye opening, verbal response, and motor response. Remember that a single GCS score is not definitive. Trending scores over time provide a more accurate picture. A patient may have a GCS of 15 when they first arrive, but if it drops to 10 within an hour, that's a red flag. Always look at the trend, not just the number. This chart breaks down the Glasgow Coma Scale. Note the different levels of response for eye opening, verbal response, and motor response, and their corresponding scores. A score of 13-15 indicates mild injury, 9-12 moderate, and 3-8 severe. As a tip, memorize the GCS scoring system. It's frequently tested in nursing and medical exams, and it's a quick tool you'll use often in clinical practice. Posturing can indicate significant brain injury. Decorticate posturing with flexed arms and clenched fists suggests corticospinal tract damage. Decerebrate posturing with extended arms and toes pointed downward indicates upper brainstem damage. Continuing our assessment, cranial nerve testing is crucial. Assess each cranial nerve to identify any deficits. Sensory and motor testing are also important to evaluate neurological function. For example, check if the patient can smile, follow your finger with their eyes, or stick out their tongue. Simple tasks that tell us a lot about their brain function. Further assessment techniques include deep tendon reflex testing, evaluation of coordination and gait, and a mental status exam. The Romberg test, as illustrated here, assesses balance and proprioception. A positive Romberg test, where a patient sways or falls when eyes are closed, can point to proprioceptive or vestibular issues. Always ensure safety when performing this test. TBI is classified into mild, moderate, and severe categories. Post-concussion syndrome, or PCS, can persist for months after the initial injury. Diagnostic tools include CT scans, CT angiography, MRI, and EEG. PCS can include symptoms like mood changes, trouble concentrating, or ongoing headaches. It's important for patients to know that these symptoms are real and treatable. Treatment for TBI varies depending on the severity. Mild TBI typically involves rest and activity restriction. Moderate to severe TBI often requires hospitalization, step-down care, or intensive care unit admission. Diffuse axonal injury, or DAI, is a common type of TBI. It involves widespread damage to brain tissue and is a major cause of unconsciousness and persistent coma. DAI often occurs with coup contre coup injuries. DAI is tricky because it may not show up clearly on imaging, but the effects are profound, often leading to long-term disability or vegetative states. Symptoms of DAI include immediate loss of consciousness and difficulty detecting on imaging. Treatment focuses on neurovascular stabilization and medications like IV mannitol or steroids. Surgery is typically not an option. Concussions are mild traumatic brain injuries. They result from traumatic forces that disrupt brain function. Loss of consciousness may or may not occur. It's crucial to cease sporting activity until evaluation. One of the biggest risks with concussion is second impact syndrome, getting another head injury before fully recovering. This can be fatal or cause permanent brain damage. The pathology of concussion involves a direct blow or traumatic force transmitted to the head. This leads to short-term neurological dysfunction that resolves spontaneously. Multiple concussions can have a cumulative effect. That's why athletes often undergo return-to-play protocols. It's not just about feeling better. It's about ensuring the brain has fully healed. Concussion pathology also involves the release of glutamate, which can be toxic to neurons. Patients may experience symptoms like seeing stars, dizziness, confusion, headache, and amnesia. Post-concussion syndrome can develop if symptoms persist. Diagnosing a concussion involves ruling out more serious conditions like cervical spine injury or hematomas. A neurological examination is essential. Remember that signs and symptoms can evolve over time, so repeat evaluations may be needed. Treatment for concussion primarily involves cognitive and physical rest. Patients should not return to playing sports or intense activity for at least 24 hours. There are no specific medications to treat a concussion. Cerebral contusions are bruises of the brain tissue. They often involve scattered bleeding on the brain surface, particularly in the frontal and temporal lobes. Contusions result from coup-contre-coup injuries or penetrating wounds. Symptoms of cerebral contusion include severe headache, dizziness, vomiting, pupillary changes, and weakness. Decreased heart rate, decreased respirations, hypertension, and inability to awaken are signs of a medical emergency. Diagnosing cerebral contusion involves CT scans, MRI, and skull X-rays. Delayed enlargement of the contusion is a common cause of clinical deterioration. Treatment options include craniectomy and evacuation of blood through craniotomy. Head trauma can lead to intracranial bleeds, including epidural hematoma, subdural hematoma, and subarachnoid hemorrhage. These bleeds present and are treated differently, so accurate identification is crucial. Epidural hematoma is a serious complication of head injury. It involves bleeding between the skull and the dura mater, often due to a fractured skull lacerating the middle meningeal artery. Rapid deterioration can occur with decreased LOC followed by a lucid period. That lucid interval is a classic hallmark. The person might get up and talk, only to collapse suddenly later, a red flag for immediate imaging and surgery. Recognizing epidural hematoma is critical. Symptoms can include severe headache, vomiting, seizure, and pupillary distortions. Diagnosis involves CT scans and skull X-rays. Neurosurgical intervention is a medical emergency. Subdural hematoma involves bleeding in the space below the dura mater, usually due to tearing of bridging veins. It's the most common type of traumatic intracranial hematoma. Bleeding is typically slow, but blood can accumulate over time. This diagram highlights the key differences between subdural and epidural hematomas. Subdural hematomas involve venous blood beneath the dura mater, while epidural hematomas involve arterial blood above the dura mater. This difference in location and vessel type explains why epidural bleeds are faster and more dangerous initially, while subdural bleeds are often sneaky and delayed. Neurological deficits in subdural hematoma may not appear until substantial bleeding has occurred. Coagulation profiles should be checked. Large acute subdural hematomas require craniotomy, while small ones may be reabsorbed. Subarachnoid hemorrhage, or SAH, can be traumatic or aneurysmal. Traumatic SAH involves tearing of vessels within the subarachnoid space. Aneurysmal SAH results from a ruptured weakened vessel, often a aneurysm. Rupture of an artery in SAH causes blood to fill the subarachnoid space, irritating tissues and putting pressure on the brain. SAH can cause obstructive hydrocephalus and brain herniation. Diagnosis involves CT scans, and treatment includes ICU management and endovascular procedures. Skull fractures commonly occur at the temporal bone, orbital fossa, base of skull, and foramen magnum. Types include linear, depressed, and basilar fractures. Linear fractures are most common and typically don't affect brain tissue. Basilar skull fractures can involve brain injury and may present with Battle's sign or CSF leak. Frontal fossa fractures can result in periorbital ecchymosis or raccoon eyes. These signs are outward clues to internal damage. CSF leaking from the nose or ears means there's a tear in the dura mater, a potential route for infection. Diagnosing skull fractures involves X-rays and CT scans. A neurological examination is essential. CSF rhinorrhea or otorrhea should be tested for beta-2 transferrin and glucose to confirm CSF leakage. Beta-2 transferrin is a protein only found in CSF, so it's the gold standard to confirm a leak. Early identification prevents complications like meningitis. Treatment for skull fractures includes pain management, examination for TBI and epidural hematoma, and antibiotics if a meningeal tear is suspected. Depressed fractures may require surgery to remove fragments and control pressure or bleeding. Thank you for watching this presentation on brain injury. Please subscribe, like, and share this video to help others learn about this important topic. Remember to study smart.